Hello, class. This is Professor Un, and this is our lecture on antihypertensive medications. We'll start with a review of the physiology of vascular smooth muscle, and then we'll start to go into the pharmacology of various antihypertensive medications, starting with a review of sympatholytics, which we went over last semester, and then we'll go into some direct vasodilators, and then nitric oxide donors, or nitrovasodilators, angiotensin converting enzyme inhibitors or the ACE inhibitors, and then the angiotensin 2 receptor blockers or the A2RBs, and then we'll wrap up with calcium channel blockers. And while we're going over those, we'll also briefly review the renin-angiotensin aldosterone system. So to start, let's go over vascular muscle physiology. So how exactly do we create smooth muscle contraction um, in the blood vessels? It starts with depolarization of the L-type voltage-gated calcium channels. And once that's opened, we'll get an influx of calcium into the cell, which will increase our intracellular levels. And the calcium will bind calmodulin. From there, calmodulin will activate MLCK or myosin light chain kinase. And this activates myosin and actin binding, and we get a muscle contraction from that. All right. Now, when the muscle contracts, it results in a decrease in the radius of the blood vessel, and as a result, we get an increase in the internal pressure. If you remember Poiseuille's law. Um, now, when we end the smooth muscle contraction and start to relax, we get nitric oxide, and it catalyzes the production of cyclic GMP. Cyclic GMP um, will then activate myosin light chain phosphatase, or MLCP, and this helps facilitate relaxation by undoing the myosin actin binding. All right. So again, some key things in play. Calcium, as usual, involved in a lot of things. Nitric oxide, cyclic GMP. So keep those in mind. Okay, now let's briefly review our sympatholytics. Remember your alpha antagonists. We have phentolamine, phenoxybenzamine, which are non-selective, and we have prazosin, which is alpha 1 selective, right? Now, when we block alpha 1 receptors, which are responsible for vasoconstriction, we get vasodilation as a result. And with alpha 2 blockade, remember that's involved with our negative feedback of our adrenergic system. So actually blocking this blocks the negative feedback will actually increase norepi release, and that could lead to an increase in your heart rate. We'll focus on an increase in heart rate because, again, remember, norepi has strong activity on beta 1 receptors, not so much beta 2, but it also has activity on alpha 1 and alpha 2. So, again, if we have a non-selective blocker in play, norepi doesn't really have the ability to bind the blocked alpha 1. So, the only thing that's not blocked is beta 1. And so, we'll see an increase in heart rate in that instance. Remember that orthostatic hypotension and reflex tachycardia, these are common side effects of alpha blockade. And we can also get cholinomimetic effects. So diarrhea, hyperperistalsis, abdominal pain. These are some of those uh, organs related to digestion that have alpha 1 receptors. So we can actually treat these effects by giving an antimuscarinic, such as atropine or glycopyrrolate. And remember, again, we have a situation where we end up stimulating beta 2 without any alpha 1 activation available to oppose it, we could get hypotension as a result of skeletal muscle vasodilation. All right, now for beta antagonists, we have propranolol, which is our prototype non-selective beta blocker. And then we have metoprolol, atenolol, esmolol. These are all beta 1 selective agents. So again, with beta 1 blockade, you'll reduce heart rate contractility, conduction velocity. You'll also reduce renin release. Now with beta 2 blockade, we get other effects such as bronchoconstriction and again, skeletal muscle vasoconstriction. So systemically, you'll see bradycardia, hypotension, which is secondary to reduced contractility and maybe renin release. Possible to see heart block, and possible to see CHF exacerbations, again, if you weaken contractility. But the other benefit is you'll see a decrease in your myocardial O2 demand, which is why we commonly use these beta blockers, specifically the beta 1 selectives, in the setting of coronary artery disease. Our mixed alpha beta antagonists, you'll remember labetalol, and there's also carvedilol, which is essentially an oral version of it. There is a mix of vasodilation without reflex tachycardia because we're also blocking beta receptors here. And we see overall less bradycardia than the pure beta 1 selective antagonists. All right. Now, remember alpha 2 agonists, they also act as a sympatholytic because, again, that alpha 2 receptor is involved with our negative feedback. So remember the agents clonidine, dexmedetomidine. So by activating alpha 2, we are decreasing the release of norepi from our presynaptic neurons. Remember that with clonidine withdrawal, it's possible to see rebound hypertension, which is pretty severe and pretty hard to treat. But you do want to try to treat this with something that's a direct acting vasodilator, if not just treat it with clonidine itself. Now, other uses of alpha 2 agonists, they're useful for analgesia, anesthetic sedation, or pre-medication. They could also enhance regional anesthesia. They could also be used to treat opioid withdrawal symptom and post-op shivering. And then here's another sympatholytic that we didn't talk about last semester, but we'll introduce now, called methyl dopa. So methyl dopa inhibits dopa decarboxylase, and that's the enzyme that's responsible for the conversion of dopa to dopamine. Now remember, dopamine has a lot of sympathomimetic activities. Dopamine itself is metabolized to norepi and epi. So by blocking the conversion of dopa to dopamine, you're stopping it a little earlier in the cascade, but overall you could decrease your levels of catecholamines, and that'll lead to a decrease in your blood pressure. Methyl dopa is also metabolized to an alpha 2 agonist. So again, we'll kind of get the same effects as clonidine or dexmedetomidine from there. Now, it's not as widely used in the US, but this is a drug that's still used pretty prevalently in developing countries. Okay, now, one of our mainstay vasodilating agents that are commonly available to us in the OR is hydralazine or apresoline. Um, the mechanism of action is direct smooth muscle relaxation, which leads to arterial vasodilation. So it does this by opening potassium ATP channels, and that causes a hyperpolarization of the smooth muscle cells. And it also activates guanylate cyclase. So remember from that earlier slide, we talked about how cyclic GMP facilitates smooth muscle relaxation. So by increasing levels, we cause more relaxation of smooth muscle. Now, A caveat to hydralazine is it can cause reflex sympathetic nervous system stimulation. So reflex tachycardia and maybe reflex contractility increase. And this is a recipe for overall an increase in myocardial O2 demand. So it's not recommended to use hydralazine in patients who have coronary artery disease or issues with myocardial ischemia. And you might also activate the renin-angiotensin-aldosterone system or the ROS. Um, and this could also lead to sodium and fluid retention. All right, so when we're using hydralazine, it'll usually come in a 20 milligram vial that's in a single ml. So it's recommended to dilute this to 5 milligrams per ml. So what you'll do is you'll draw up 3 mLs of, saline, and then you'll draw up this to make 20 over 4, and that's how you get 5 milligrams per ml. Now, our starting dose, anything between 2.5 milligrams to 10 milligrams is reasonable. My recommendation is just go right for 5 milligrams or 1 cc at a time. Now, a key thing about hydralazine is the onset is slow. It takes about 10 to 20 minutes. So it's best practice to wait for the full effect before you start to throw on an additional dose. And the reason why you want to be so judicious with using it is because the duration is quite long. It can be up to 2 to 4 hours, so it's unpredictable, in other words. And so you're making this long commitment to vasodilation, right? Um, so definitely do not be aggressive with the dosing. Be patient with it, because if you overshoot it, you're stuck with that for several hours, right? Um, Now, hydralazine undergoes a hepatic metabolism, renal excretion. You might see a prolonged duration in liver disease. It's useful in treating chronic heart failure, preeclampsia, and severe hypertension. And another thing is it's a potent cerebral vasodilator, and it inhibits cerebral autoregulation, which could lead to increases in your ICP. And long-term use of hydralazine, as a fun fact, has been associated with a lupus-like syndrome and aplastic anemia. So probably not recommended to be chronically on hydralazine. All right, let's talk about the nitro vasodilators. So, um, we'll start with nitric oxide. It has a large role in regulating vascular tone throughout the body. So, nitric oxide is something that we endogenously produce and have available. It's also involved in platelet regulation, our immune response, and it also acts as a neurotransmitter when it's in the CNS. So it has a lot of different roles. Now, it's synthesized in endothelial cells by nitric oxide synthetase, and that's derived from L-arginine, which is one of those amino acids we learned about in back in our biochem in undergrad, right? So the mechanism of action of nitric oxide, we actually talked about it already, but remember, in vascular smooth muscle, this induces guanylate cyclase. And again, that causes an increase in cyclic GMP, which leads to vasodilation and overall a reduction in our peripheral vascular resistance. So nitric oxide is avidly bound by hemoglobin, which means it's rapidly inactivated, and the half-life is less than 5 seconds. So um, when it's bound, it forms nitrosyl hemoglobin, and that's when the nitric oxide binds the iron atom in hemoglobin. And it can react with oxyhemoglobin as well, and we'll get a formation of methemoglobin plus nitrate. Now, under normal physiologic conditions, we don't really have to worry about, methemoglobinemia because the levels of methemoglobin are regulated and our system can compensate for, the amounts of nitric oxide that uh, react with oxyhemoglobin. Now, there's also an inhaled form of nitric oxide, which acts as a selective pulmonary vasodilator. So, this is useful in the setting of severe pulmonary hypertension or right heart failure, lung or heart transplant, pediatric lung injury, or even a persistent pulmonary hypertension in neonates. So, with inhaled nitric oxide, you might actually see a modest increase in methemoglobin. Another thing you might encounter is rebound arterial hypoxemia and rebound pulmonary hypertension as well when it's discontinued. So the recommendation is to wean off slowly if somebody is on this. Okay. Sodium nitroprusside, we'll abbreviate that SNP going forward. Um, so this one's interesting. Take a moment to appreciate the structure here, and we'll see we have an iron center with a nitrosyl group. And aside from that, we have five cyanide groups attached. So, how does SNP work? It spontaneously releases nitric oxide and causes potent arterial and venous vasodilation. And so what we have going on is electron transfer from the iron in oxyhemoglobin, and that destabilizes the molecule, which will cause another electron transfer and get, methemoglobin plus the release of the nitric oxide and the release of five cyanide molecules as well. So physiologically, we'll see both a decrease in preload and a decrease in afterload because it's, potent vasodilator of both the arterial and venous systems. Um, we'll see baroreceptor reflex activation. So you'll probably see, compensatory tachycardia and increase in contractility as well, which is just the body's attempt to counteract the potent vasodilation that occurs. Um, there's concerns with, maybe we'll see some coronary steal. Uh, it could also abolish cerebral autoregulation. So again, we might see increases in ICP. Decrease in pulmonary artery pressure, inhibition of hypoxic pulmonary vasoconstriction, which could actually increase your VQ mismatch, right? And that could lead to an overall decrease in your PaO2 or your arterial oxygen pressure. Um, Now, it is a very rapid onset drug. It's pretty much immediate, and it is also a very short duration drug. So, with a pharmacokinetic profile like this, it allows for nice, precise control of blood pressure when you infuse it. The drug itself is also subject to photodegradation. So, when you set up your infusion, they recommend that the bag is wrapped up in foil or black plastic. And our initial dose of this drug is anywhere from zero point 0.3 to zero point 0.5 mics per kilo per minute. And you can titrate it up. You want to start to be careful once you're at two or more mics per kilo per minute. For more than a few hours, we have to watch out for cyanide accumulation or toxicity, which we'll go into a little more on the next slide. And the absolute max you could run your SNP is 10 mics per kilo per minute for no more than 10 minutes. So it's kind of easy to remember 10 for no more than 10, right? Um, so going into the cyanide metabolism, what normally occurs in the body is we have a few different pathways. So cyanide will react with methemoglobin to create cyan methemoglobin, and this compound is non-toxic. So normally 1% of our hemoglobin is naturally in a methemoglobin state, and this can bind the released cyanide from up to about 18 milligrams of sodium nitroprusside, right? Now, so that's how much we have in the met hemoglobin reservoirs. We could accommodate up to 18 milligrams of SNP. Now, we also have another pathway where we'll see cyanide molecules are metabolized by hepatic and renal rhodinase enzymes, and that results in thiocyanate. Now, this requires sulfur for this process. Um, Now, most adults' existing sulfur stores can detoxify about 50 milligrams of SNP. So again, we have a much larger reservoir here in this rhodinase enzyme thiocyanate pathway, right? Now, the caveat here, thiocyanate is slowly cleared renally. So I would be very hesitant to use SMP in somebody with renal failure because even though they have this pathway to deal with the cyanide, accumulation of uh, thiocyanate can be problematic in somebody with bad renal function. Um, Now, the other pathway we have, right? Well, actually, let me see. No, yeah, I think that's right. So these are our main two pathways, right? So once we exhaust the methemoglobin stores and all our sulfur stores, right? Cyanide will start to bind tissue cytochrome oxidase. And this is where it becomes problematic because when we bind cytochrome oxidase with cyanide, we inactivate our mitochondrial electron transport chain, and this makes cells unable to use oxygen, right? So this is where we get that, the toxic effect of cyanide, right? And again, without O2, things start to die, right? So acute cyanide toxicity occurs usually when your SMP dose exceeds more than 500 mics per kilo. Some hallmarks of it are, lactic acidosis makes sense because we've made cells unable to use our, aerobic metabolic pathways, so they're going to resort to anaerobic metabolism, right? Um, you might see cardiac arrhythmias, again, probably due to overall ischemia. The heart doesn't like ischemia, right? And that's one of the causes of arrhythmias. And another hallmark, this is one you should definitely know for boards, is that when we have cyanide toxicity, we'll actually see an increase in venous O2 content. So if you think about it, this makes a lot of sense because we've basically, with the cyanide, made our cells unable to use oxygen, right, in the electron transport chain. So all that unused oxygen is showing up here on the venous side, right? Um, Hopefully that makes sense, right? Now, when we're in acute cyanide toxicity, our SMP stops working as a vasodilator. We'll actually start to see the opposite and see hypertension, right? So this tachyphylaxis or resistance to increasing doses of it. So how do we treat the acute cyanide toxicity caused by SMP? Obviously, stop the infusion, um, right? We're gonna switch to 100% FiO2. We're gonna administer sodium thiosulfate, and this helps to increase our sulfur stores so that we could keep taking advantage of this rhodinase enzyme pathway. And we're also going to increase our um, methemoglobin stores by giving sodium nitrite, right? So again, trying to feed both of the pathways that we have to deal with cyanide, right? And there's also something called hydroxycobalamin uh, or hydroxycobalamin. I'm not sure if that's supposed to be a Y there or not, but in other words, vitamin B12A that helps convert cyanide to vitamin B12. Now, one caveat to this is it might cause red discoloration of skin. I don't think patients will mind that if you're saving their life, right? So I'd rather have a little red discoloration than be, dead. So, anyways, yeah, but that's one of the known side effects of this treatment pathway, vitamin B12A. All right. Anyways, moving on, we got nitroglycerin. We'll abbreviate that as NTG going forward. Now, molecular structure is obviously much different than sodium nitroprusside. There's no sign of cyanide anywhere, which is a good thing. So, how does this one work? Its mechanism of action. We are taking advantage of enzymatic conversion to nitric oxide. So we administer nitroglycerin, it gets converted to nitric oxide, and then we'll get the same effects where we'll get venous and coronary vasodilation. Not so much arterial for this one. Now, this is dependent on the glutathione dependent pathway. So this makes its onset slightly slower than SMP, but overall, nitro still has a very rapid clinical onset. It does cause a decrease in preload, again, because we're dilating on the venous side, and we have increased venous capacitance. Now, at really high doses, you might start to see arterial smooth muscle relaxation and also pulmonary vasodilation. So NTG, we remember from our ECG class, this is one of those treatments for acute coronary syndrome, right? So it's useful for treating angina, myocardial ischemia, coronary vasospasm, hypertension, of course, LV failure, and it's also useful for treating cardiogenic pulmonary edema. Um, the IV infusion can be used for controlled hypotension if that's something your surgeon is looking for. But because it's more preferential on the venous side, that kind of makes it less useful in treating severe hypertension. We have better agents that will act more on the arterial side, which we'll kind of talk about later, besides SNP. Um, and another caveat to nitro is, again, it will, just like SMP, it'll kind of increase your cerebral blood flow and your ICP, might cause headaches. Definitely want to take caution in patients who are already at risk of high ICP, like, brain tumors and whatever. So to compare to SMP, some of the key differences, maybe there's minimal heart rate changes. In theory, maybe less reflex tachycardia. I put a question mark there though, because I think clinically you still will see a compensatory increase in heart rate, but this is what your text says. Now, there's no rebound hypertension when you discontinue. There's also less effect on decreasing afterload, because again, this is not as much an arterial dilator as SNP is. Um, Now, on the plus side, there's no cyanide risk, but it may cause methemoglobinemia due to the nitrite metabolite, right? And this is especially increased in patients who have hepatic failure. Tolerance might develop. This is dose and duration dependent, and tolerance is just not something you see with SNP. But of course, I don't think we're really running SNP long enough for this to occur anyway. You'd probably see toxicity beforehand. Now, you might also get some bronchodilation, which, this is not really a first line treatment uh, for bronchospasm. So, we have better agents for that, but just know that this is in theory possible. Um, and nitro is actually also effective as a transient uterine relaxer, right? Or uterus relaxer. So there are few use cases where in the OB setting, you might be asked to give a bolus of nitro while they, you know, try to do a version or something like that, where they just need transient uterine relaxation while they, reposition the fetus or something like that. So when we dose nitro, your infusion is anywhere from zero point 0.5 to 5 mics per kilo per minute. Um, and again, for that use of transient uterine relaxation, you might want to bolus 50 to 100 mics. There's other routes of administration as well. An oral version. Uh, this is subject to significant first pass hepatic metabolism, as you would expect. There is also a sublingual version or transmucosal version, which helps to avoid first pass metabolism. So a little bit better than an oral version. And there's also a transdermal system where, it delivers 5 to 10 milligrams over, 24 hours. And you could get sustained protection against a MI with this. But again, because this is kind of long-term use and prolonged exposure, this is the format where you might see tolerance develop, especially after the first 24 hours of using it. Okay. Um, so I just made this table to kind of help you guys compare SNP versus NTG and kind of see big picture distinguishing features, right? Um, so take a moment to get familiar with this. Obviously, some of the key points I've already talked about. We get equal arterial and venous dilation with SNP, but with nitro, more so just venous than arterial. Pretty much rapid onset. I mean, immediate for SNP, but it's only about, 1 minute away for NTG or maybe up to 3 minutes. Very short half-life for both. Nitro has more routes. Sorry, nitroglycerin has more routes available. Both are nitro, right? SNP, again, if you see tachyphylaxis, that's a big red flag for cyanide toxicity. Whereas nitroglycerin, we're worried about maybe tolerance happening with prolonged doses. Again, primary uses, a little bit different here. Nitroprusside is really just kind of an intraoperative thing where you either need to control severe hypertension or you want to cause controlled hypotension. This used to be a mainstay for vascular surgery whenever a aortic cross clamp was involved. But nitroglycerin has a little more variety of uses and not just in the OR setting, right? We talked about metabolism, not of nitroprusside here. Again, this is, remember, this metabolism refers to the cyanide. Nitroprusside itself is just immediately broken down to its various components. Nitroglycerin undergoes liver and blood reductive hydrolysis. And again, we worrying about toxicity. We have cyanide as an issue with S&P, whereas with nitroglycerin, maybe methemoglobinemia, which is rare, but higher risk when we have a liver dysfunction. All right. Uh, okay. Now let's review the renin angiotensin aldosterone system. So the ROS is activated by hypotension, reduced renal perfusion, and that's mediated by our juxtaglomerular cells. Um, could also be activated by hyponatremia, and that's going to be mediated by our macula densa cells. And it could also be activated by sympathetic stimulation, which is mediated by our renal beta 1 cells or receptors. Sorry. Um, so the liver contributes angiotensinogen. The kidneys contribute renin. Renin converts angiotensinogen to angiotensin 1. Now our lungs contribute angiotensin converting enzyme or ACE, and that converts angiotensin 1 to angiotensin 2. Now, angiotensin 2 is where we is the point in this pathway where we start to get the clinical effects we're looking for, right? So angiotensin 2 causes direct vasoconstriction itself. And it also stimulates aldosterone secretion from the adrenal glands. And it also stimulates antidiuretic hormone release, which, uh, will help with water retention. And angiotensin 2 also enhances norepi release, and it also increases our sympathetic nervous system tone, right? So responsible for a lot of things. Now, aldosterone, which is released by our adrenal glands, and again, that's triggered by angiotensin 2, but aldosterone is responsible for stimulating sodium reabsorption, and thus water will follow sodium. So we'll also get water retention. And this causes an overall increase in our intravascular volume. At the same time, aldosterone also promotes potassium and hydrogen excretion. So something that I was taught when I was in my training to easily remember aldosterone's function, you could think of aldosterone as the agent that's responsible for saving sodium, peeing potassium, right? SSPP. All right. So hopefully that one sticks and it's easy to remember, and you'll never forget what aldosterone does. All right. So now that we've talked about the ROS, we can talk about blocking uh, certain parts of that pathway now. So we'll start with our ACE inhibitors. Obviously, the mechanism is that they inhibit the conversion of angiotensin 1 to angiotensin 2 by inhibiting the angiotensin converting enzyme, right? Now, again, when we have less angiotensin 2 available, uh, angiotensin 2 binds something called the AT1 receptor. So by decreasing this, we have less activation of the AT1 receptor, and this causes an overall decrease in calcium release and also a decrease in vasoconstriction. Now, another thing that ACE inhibitors do, they block the breakdown of bradykinin. Um, Bradykinin, we've briefly talked about it before when we talked about propofol, but this is a endogenous vasodilator. So again, the reason why propofol burns when it's injected, the phenol group is irritating to, you know, the blood vessels, and the endogenous release of bradykinin exposes more surface area of those blood vessels to the phenol group. So um, that is the proposed mechanism for why propofol burns. Anyways, bradykinin, vasodilator. So ACE inhibitors are considered a first-line therapy for systemic hypertension as well as congestive heart failure. They may reverse LV hypertrophy, which is a common compensation that you'll see in chronic, long-standing hypertension. It could also improve outcomes in diabetics. And we'll see, because of our decreased levels of angiotensin 2, we'll also probably see decreased plasma aldosterone, which means less sodium and less water retention, right? So it's possible to see maybe even hyponatremia and hyperkalemia as a result. Um, some of the, benefits of ACE inhibitors is that you don't see some of these negative side effects, such as depression, insomnia, sexual dysfunction, electrolyte imbalances, uh, CHF, bronchospasm, bradycardia, rebound hypertension. These are all side effects that we might potentially see with other antihypertensive medications, such as beta blockers. Now, your ACE inhibitors will be followed by the suffix pril. right? So the most common one we'll probably see is lisinopril, but there's also captopril, enalapril, ramipril. Now, in this particular order, um, this is going in order of increasing duration. So lisinopril is, the second longest acting one, only outdone by ramipril, which is the longest acting ACE inhibitor. Now, common side effects of our ACE inhibitors that we do see is a cough and you know, upper airway congestion or rhinorrhea, maybe even allergy-like symptoms. Now, a severe one is angioedema, right? So it's something to watch out for with ACE inhibitors, especially for us, because if a patient has angioedema, that is a recipe for a very difficult airway. We'll probably see a decrease in GFR, so caution in renal dysfunction or patients who have renal artery stenosis. And again, hyperkalemia might be an indirect effect due to decrease in aldosterone. Now, obviously, you're already familiar with this issue, but ACE inhibitors are associated with prolonged hypotension, especially when you combine it with general anesthesia. So you know, the term they coined for this is vasoplegic syndrome, and this is essentially a dysregulation of our nitric oxide synthesis as well as a increase in our vascular guanylate cyclase activation. Again, remember guanylate cyclase increases cyclic GMP, which causes smooth muscle relaxation. So, vasoplegic syndrome, the hypotension associated with ACE inhibitors plus general anesthesia, it's very difficult to treat. It will be resistant to a lot of our first line pressors like phenylephrine or ephedrine. So it may require vasopressin if it's unresponsive to your first line sympathomimetics and if you're still unresponsive to a fluid bolus. And the other thing we have available to us is methylene blue, actually. Um, so how is methylene blue helpful for treating vasoplegic syndrome? It inhibits guanylate cyclase, which will help decrease our levels of cyclic GMP and essentially counteract the excessive nitric oxide mediated vasodilation that's going on here. Now, best practice, it is recommended that patients withhold their ACE inhibitors 24 hours prior to their surgery if they're receiving general anesthesia. All right. Now we have the angiotensin 2 receptor blockers. You could call that, the A2RBs, or if you just want to make it easier, ARBs, right? ARBs. Um, Obviously, the mechanism of action is in the name, but they are a competitive antagonist at the AT1 receptor. So by inhibiting the AT1 receptor, we are inhibiting the vasoconstrictive effects of angiotensin 2. However, there is also an AT2 receptor that we're leaving available. Now, the AT2 receptor uh, promotes vasodilating effects when it's bound by angiotensin 2. So it's weird. Angiotensin 2 has, both vasoconstricting and vasodilating activities depending on which receptor it's on. But the AT1 receptor is more responsible for vasoconstriction. So we're blocking that one, but we're leaving its vasodilating pathway still open at the AT2 receptor. All right. These drugs have the suffix sartan. So again, very common one we'll see, losartan, irbesartan, candesartan, olmesartan, valsartan, right? These all have a relatively long duration and they only require once or twice daily dosing, PO. Losartan has active metabolites that actually have a longer half-life and more potency than the parent compound, and it's eliminated by the liver and kidneys. Um, the ARBs do not inhibit the breakdown of bradykinin like ACE inhibitors do. And this is perhaps why our ACE inhibitors are preferred as a first line therapy because we have that additional pathway for vasodilation through bradykinin here. Um, However, on the plus side, as far as side effects go, the ARBs do not cause coughing like the ACE inhibitors do. The coughing is a big issue with the ACE inhibitors. It's probably one of the top reasons patients can't tolerate these drugs and eventually have to get switched just because the coughing is so, tedious and bothersome. Okay, so again, summing up our ACE inhibitors and our angiotensin 2 receptor blockers, review of mechanisms. We're decreasing angiotensin 2 levels overall by inhibiting conversion of angiotensin 1 to 2, right? We also get a decreased activation of the AT1 receptor, which means we're decreasing the amount of vasoconstriction that's caused by the AT1 receptor, right? Um, and we're also uh, preventing the breakdown of bradykinin, right? So this is the benefits of our ACE inhibitors, right? So if we leave bradykinin intact, we get more vasodilation. Now with the A2RBs or the ARBs, we're just blocking the AT1 receptor. AT2 is still intact. Overall levels of angiotensin 2 are unchanged. So, yeah, basically, there's still enough of this available to activate the AT2 receptor, but um, the breakdown of bradykinin is not prevented by this one. All right, cool. Our calcium channel blockers, this particular class that we're focusing on are called the dihydropyridines. All right, so their mechanism of action, the dihydropyridines, is that they inhibit calcium influx via the voltage-gated L-type channels. So remember, this is that first step in smooth muscle cell contraction, right? Um, these drugs are highly selective for vascular smooth muscle, and we get the benefit of arterial vasodilation with these ones, while there's very little effect on venous circulation. Um, we also get coronary vasodilation. Um, So yes to arterial vasodilation, very little venous, and yes, we get coronary vasodilation, right? Um, these are relatively safe to use, even in the setting of cardiac conduction defects or heart failure. There's less effects on preload here because we're not really touching the venous side, but we do reduce afterload, which is beneficial in this setting of heart failure. Now, the dihydropyridines, logically, the suffix makes a lot of sense. Dihydropyridines, dipene, right? So kind of a shortened name for their, class. So all the drugs in this class will end with dipene, amlodipine, right? Um, that's probably one you've heard of. Um, and again, the dihydropyridines, they act more as vasodilators rather than antiarrhythmics. So we have minimal effect on chronotropy and dromotropy. Uh, Again, these are very highly selective for vascular smooth muscle, not so much cardiac tissue, right? So useful for hypertensive emergencies as well as intraoperative blood pressure control. And studies show you actually achieve better blood pressure control using calcium channel blockers versus the nitrates. And again, we don't have to worry about cyanide toxicity with these guys, right? So another added benefit. Um, so to go over some examples of dihydropyridines, let's start with nicardipine. Brand name is Cardine. It's a really great drug. It has a rapid onset within 1 to 3 minutes, and also a very, relatively short duration of action, which is, anywhere from 10 to 30 minutes. But honestly, clinically, I think it could be even less than that because when I titrate this drug on and then I titrate it off, I pretty much see the clinical effect gone in a matter of, few minutes. I've never seen it last as long as 30 minutes, but maybe with a prolonged infusion, it could be. Anyways, this is one of the strongest vasodilating drugs among the calcium channel blockers. It is dependent on hepatic metabolism. So you want to watch out in hepatic failure, might see increased plasma concentrations and a prolonged duration there. Now, these drugs are considered relatively contraindicated in advanced aortic stenosis. So let's think about this. This makes sense because we have strong reductions in afterload. Remember, when you have aortic stenosis and you have blood exiting the aorta in a jet, right, through the narrowed valve at a high velocity, that makes it a lot harder to perfuse the coronaries unless you have a high afterload to counteract that, that high velocity jet going through the narrow aortic valve. So again, you want to be cautious. It's probably okay to use it if there's mild aortic stenosis, but you should probably avoid it if they're at a moderate to severe grade aortic stenosis. The dose, now it's recommended to infuse this drug because of its short half-life. And the starting dose starts at 5 milligrams per hour, and you titrate up 2.5 milligrams per hour at a time. So increments of 2.5, and you could go all the way up to 15 milligrams per hour. Um, I've heard of it being bolused before, and that's probably okay. Um, I would just do a very small dose if I'm doing it like that. I don't even have a dose actually that I could recommend because I've never done it that way myself. But I've heard of that being practiced at certain hospitals is, it's okay to give a very tiny bolus of this if you just want a very transient effect. All right, now clevidipine, brand name Cleviprex, also a IV drug only. Similar pharmacokinetic profile, has rapid onset, 1 to 4 minutes. But this one is considered ultra short acting, so much shorter than nicardipine actually, anywhere from 5 to 15 minutes, so about half of nicardipine's duration. And why is that? No surprise here. It's because it's metabolized by plasma and tissue esterases. Now, the cool thing about this is that means clevidipine is unchanged in the setting of, hepatic or renal failure because it's not dependent on metabolism by either organ. Um, and the other cool thing about clevidipine is that it comes in a lipid emulsion, so it actually appears white, just like propofol does. Now we have to consider the same things that we had to consider due to propofol's lipid emulsion. So, avoid in patients with a egg or soy allergy, maybe. Again, probably egg yolk is the more problematic component, but most people's egg allergies are to egg whites, right? Remember that. Um, Watch out in people who have impaired lipid metabolism. It can support bacterial growth, so you want to use it within 12 hours of being drawn up. And again, the dose, it must be infused. You start at a dose of 1 to 2 milligrams per hour, and you titrate by just doubling the dose. So you can start at 1, go to 2, go to 4, go to 8. Your max dose is going to be 16 milligrams per hour. All right, now we have some other over the count, well, not over the counter, but drugs that could be taken at home among the dihydropyridines. So nifedipine or Procardia, you can take this PO. This is used typically for angina, especially for coronary vasospasms. There's other uses such as cerebral vasospasm, prophylaxis after a subarachnoid hemorrhage. It could be used as a tocolytic, right? Um, in other words, reducing uterine contractions. And it can also be used in Raynaud's syndrome. Again, if you've heard of Raynaud syndrome, this is a condition where people have really poor perfusion to uh, their digits, like their fingers. They tend to get really cold. So a little arterial dilation there to help promote more blood flow to the fingers, basically. Um, you do want to take caution. Large doses may acutely lower blood pressure and cause myocardial ischemia, right? So, yeah, um, kind of obvious there. Don't overdose it. Amlodipine, Norvasc, this is a very common one, and this is taken PO, used for the management of hypertension. It's essentially a oral version of nifedipine or nicardipine, which I guess is kind of redundant. I already told you this is an oral version, but um, amlodipine, it's nice and simple. It's just once daily dosing. Um, Now, the non-dihydropyridine calcium channel blockers, uh, there are other classes of calcium channel blockers, such as the phenylalkylamines and the benzothiazepines. These are actually more useful as antiarrhythmics rather than vasodilators. And we'll talk a little bit more about these classes of calcium channel blockers in the antiarrhythmics lecture. Um, Now, what are some possible adverse effects of our dihydropyridines? Reflex tachycardia is actually quite common. Um, Again, you might see negative inotropy in theory because there might be a tiny bit of overlap in calcium channel blocking activity, but this is usually minimal unless, you have a patient who is high risk of heart failure, then it's possible there, and it would also be very detrimental in those patients. Um, there's also inhibition of hypoxic pulmonary vasoconstriction. So again, there's that possibility of worsening VQ mismatch and decreasing our arterial oxygen. Um, and nifedipine, interestingly, might actually cause an increased glucose in diabetics. So just a weird quirk with that particular drug. So again, contraindications to these dihydropyridines, right, are vasodilating calcium channel blockers is, again, aortic stenosis. Be very careful with causing a drop in afterload because that will in turn cause a drop in your coronary perfusion pressures. And also, you want to be careful in decompensated heart failure. So, I couldn't find a hard cutoff here, but if patients have a, ejection fraction that's less than 40%, maybe. Um, it's a situation where you'd want to think twice about using one of these. So again, making another table to kind of sum it up for you guys and make it easy to compare drugs. So when we talk about effects on inotropy, we really see none with nicardipine and clovidipine, maybe just tiny amounts. Now, nifedipine does definitely causes a slight decrease in inotropy. And then verapamil, diltiazem, these are those non-dihydropyridine calcium channel blockers that I mentioned. We'll go into more detail in the antiarrhythmics lecture, but they might have no effect or maybe just trace amounts of decrease. Notice chronotropy, dromotropy, our dihydropyridines have no effect there. We do get profound peripheral vasodilation, profound coronary vasodilation. Reflex tachycardia, some with nicardipine and clovidipine, more with nifedipine, right? But again, our antiarrhythmic ones will get obviously a strong decrease in dromotropy. That's what we use them for, with minimal vasodilation, coronary dilation, right? So again, we'll go into those next lecture. That's all I have for this one. If you have any questions about anything, as always, feel free to email me, and I'll see you guys in class.